good evening, and welcome to your weekly medical show. This is going to be one of your favorite shows, Ask Dr. Saw. In studio is Dr. Saw, and I just want to say that the response has been overwhelming so far, and I cannot say thank you enough for the support that you guys have shown us on this show. This show is an informative show, and very, very soon, in 2 weeks, you are going to have the opportunity to call in and ask us questions. This show is going to go live in 2 weeks, and you are going to be part of this panel and part of the discussion, and you will be able to ask Dr. Saw anything. So, Dr. Saw, welcome again. This is your show. How was your weekend so far?
Oh, it was good. A bit hectic. I'm just, seeing this as part of a holiday as well. So the fact that I'm new in the sense that I just came back.
Great.
So,
great.
trying to catch up and things.
Did you go to any of the cricket so far?
No, I looked at it on television.
Yeah.
Excited.
Me too. I watch on TV these days.
Yeah.
Just to pick up from where we left off last week, folks, we were talking about diabetes, and we were talking about a number of things. Where we were the complications involved in it with diabetes. And Doc, I wanna share something with you. Let's just start off tonight's show. Someone, after watching the show, messaged me and asked about look, they lost a leg, and they asked about it. How does someone know, or what causes people with diabetes that it leads to the stage where there's a lot of times amputation? Sometimes a toe has to be cut off, a finger, an arm or a leg. What causes that, Doc?
Right. So that's a complication of diabetes, and is something that we used to see a lot in the old days. Thank God for now we have more awareness, we have better management, and patients we avoid those complications. But coming to why you have an amputation, the most common cause would be an infection to the leg, to the foot, leg, wherever, and you have ascending infection. That is, the infection goes up, and you have to keep cutting the distal part, that is the part that is infected, to save the leg, and also to save the body as such, because if you have infection, it goes up into the body and you can end up with something called sepsis, where it eventually leads to death. Now, I touched the last time a little bit on the complications of diabetes, and I said to you that diabetes is a metabolic disease. That is, it affects the whole body. And when I looked at the brain, the heart, the eyes, kidneys, but coming down to the leg, there are two components to that. So when you have an injury, so you have a nail stick injury, that's a common cause, because diabetes affect the nerve, and then you don't feel properly in your feet. And what tends to happen, you have an injury and it get infected, you're not aware of it until it's too late. Now, there are a combination of factors. So one would be infection. So when you have diabetes, if the sugar is high, your body's ability to fight infection is weakened. So infection, would have a grip on you more than if you didn't have diabetes. So that is one factor that is involved. The second thing is, as diabetes cause increase what we call peripheral vascular disease. That is, it affects the blood flow to the leg. So if there's less blood, the body has white blood cells and red blood cells. Red blood cells transport oxygen, white blood cells fight infection. So if there is less blood flow to that area, there's less chance of the body being able to fight the infection that is there. Then infection ascends and you have to end up with an amputation. And that's a common cause of the amputation, and it's something that we are wary of, and we try our best, for it to prevent it.
Wow. Yeah, because I've seen a lot of people, people that I know, and they're telling me, what's happened with you? I say, well, I have diabetes and I had to take and I'm thinking, well, what causes this,
Yeah.
So thanks for clearing that up. There are a number of things that we're going to be looking at, I'm sure, throughout the life of this show, and that affects people here. And there are all of these myths surrounding things also. And I'm happy that we can bring this to the table also, that we can break those down.
Sure.
And see what makes what makes good sense and what is actually should be dealt with in a medical way.
Yeah.
So on complications, though, what else do you want to?
So we touch. I always like to explain complications in a way patients can understand and to remember also. So when we look at the complications, I will just share a slide here that I shared before. So I start from the head. So I said diabetes increases your risk of stroke. So that is starting from the brain, the head. There is the risk of stroke because you have a blockage of the blood vessel, leads to stroke. It also, there's something called a vascular dementia where poor blood flow to the brain causes dementia or poor memory. Now, coming down the eyes, we know that diabetes can cause blindness. You have bleeding at the back of the eye, and then you have an area, a light-sensitive area in the eye called the macula, and you have something called maculopathy. So it is important, part of the good management of diabetes is for you to go and see your doctor, at least your eye doctor once a year, and we have that as routine. Now, heart, diabetes increases the risk of heart attack, that is the blood flow. So anything that has to do with blood flow would cause problem. I mean, you will have problem due to diabetes. Now, kidney, we said that initially you have leakage of protein into the urine, and you have nephropathy, that is called. The nerve, you have something called neuropathy, where you have numbness or pins and needles or different problems with the nerve in your legs. So in that case that we spoke about, where you have a needle stick injury, we would say that's a combination of possibly three things. One, poor infection control as in the body's ability to fight infection. Two, there is neuropathy where the patient did not feel in the initial injury, so the nerve is affected. And three, you have poor blood flow for the body's ability to fight infection. So those are the components.
Well, thanks for that, because so actually a lot of times you hear people say that when they have this, when you got sugar and you get a cutter, so you don't know.
Yes.
And I'm happy for you to say, why is it that we don't know? Because this person, that they probably would have stepped on that nail and didn't feel it, and it didn't take it for anything, and by the time you catch it,
absolutely,
it has already become infected.
Correct, yes.
So
that's a common thing.
Yeah.
You don't feel in your legs, and you have what we call glove and stocking. So when we talk about neuropathy, that is, the nerve is affected as a result of uncontrolled diabetes. It presents like a glove and stocking presentation, where gloves both hands, both legs. So it starts distally. So your feet, you start not feeling from the feet coming up, and then from the hands going that way. So glove and stocking neuropathy. So you get numbness in your fingers. You can't feel extremities. Correct.
Right.
So that's a common presentation.
Yeah. Well, I hope our viewers are taking this in, and so somebody who has diabetes, and should they do self-examination ever so often?
Oh, obviously. Indeed. So it will be, self-examination is important to take care of your feet and your hands and your body generally. But part of the management, which I'll tell you, that there are some specific things you have to do that we do every year.
Oh, wow.
We have those patients going to see the nurse, and they will have foot check. That is, we check the pulses, and we check for neuropathy. We check for the sensation.
Oh, great.
So it is important that when you go to see the doctor, a diabetic patient sees a doctor, the doctor will, yearly at least, they will check your sensation in your feet. So they will do different touch, light sensation, pin prick sensation, and see if you can feel. And those, if you can't feel, those are signs that, feeling numbness, whatever you're having.
I saw on the chart up there just now. We put up back the chart. The next one you have there is erectile dysfunction.
Oh yes.
A lot of times people think that dealing with that is kind of taboo, but I think it's very important, especially as us men. We need to know about what can cause erectile dysfunction.
Absolutely.
And it seems it's one of the complications of diabetes here.
Yeah. So this is something, of course, as you said, it's a taboo. People don't talk about it. They're not open about it. But I would want us to probably do a topic on erectile dysfunction on its own, because that's a big topic, and there are lots of things we can do. But just to touch on it briefly in diabetes, I said to you that diabetes affects the blood vessel. Now, blood vessel, the brain, erection has to do with blood flow.
Yes.
Heart has to do with blood flow. So and stroke has to do with blood flow. So if it affects the brain and it affects the heart, of course it will affect the erection because there's poor blood flow to the penis. And if that's the thing. As a matter of fact, lots of times nowadays, once patients start having erectile dysfunction, we start looking at their heart.
Okay.
Because that can be a warning sign to say, hey, something's wrong. Also in diabetics, and I mean, I find this in my, lots of my diabetic patients, because it's a metabolic disease also, they have low libido, low testosterone.
Right.
So there are two components of erection where you don't have the drive to do something, and also you can't have the erection strong enough. So if you can't have it strong enough, it could be because there's poor blood flow to the penis, and also if you don't have the drive, you don't have the hormone. You have, like, woman has got menopause, men we call the andropause, and they have low testosterone, and we find that a lot in diabetics. So if I have a diabetic patient who said, "Doc, I'm tired, I have low sex drive, I have erectile dysfunction," I would also test their testosterone level. And that gives us an idea. If it's low, of course, you can give testosterone supplement. We give them it in the form of an injection every 3 months. So those are some of the things we look at. But it is very important.
I have so many questions as it relates to that, but I'll wait until that topic comes up. And viewers, I just want to know, while we're doing this for half an hour now, when our live call-in starts in about 2 weeks, we are going to be doing it for 1 hour. It's going to be a 1 hour program, and you are going to absolutely love it. So on the side of complications, though, have we covered?
Yeah, I think we have covered most of it. I mean, in terms of the organs and what can be affected. But I would want to say, you mentioned something about what do we do in the, like, looking for these complications.
That's right.
In terms of routine care. This is the gold standard. That, I mean, in the UK, for instance, I do that to all my patients. So we want a couple of things I want to emphasize when we talk about monitoring of diabetics. So I want diabetics patient to at least be aware of this, and then they can ask their doctor, okay, are we up in speed with all these things? So one, we want your sugar to be well controlled. And that is measured by looking at your fasting sugar and your sugar after eating. So there are 3 types of sugar tests. One is the fasting sugar, one is postprandial sugar, that is after eating, and the average sugar is called the HbA1c. Now, looking at those 3 readings can give us an idea how well it's controlled. 2, we want blood pressure to be well controlled. Normal blood pressure, 140/90 under, 140/90 we want, but in diabetics we want it even lower than that. We want, your target should be 130/80.
Okay.
So we want blood pressure to be well controlled. Thirdly, we want your cholesterol to be well controlled. Now, cholesterol levels, we want it lower than the normal. For instance, in the UK, the normal cholesterol level, we average about 5, which is about 200. In the US and Guyana, we want that to be lower, as in 4. You multiply by 38.6. It's the conversion rate for that to cholesterol.
And Doc, before you move on, you are giving us here the measurement in units that are in UK, and you're giving us a conversion that is US standard.
Correct.
So it's because I want to clear that up, because there's a question that I took from our previous show that we did last week, and I will relate that to you. But I just want to make that clear, that what you're giving here, the units of measurement that you're giving when you're giving units of measurement that is UK standard and
the US, which we use in Guyana, the US units. So the units are just the units that are used to measure it. So because I have viewers and my practice has been for years in the UK, I have lots of UK patients who will be looking at the show as well.
Indeed, right.
So I want to cover both sides. Now, so if you're looking at the cholesterol level at 200 in the US, we're looking at about 5 in the UK in terms of their units of measurement. Now, the 4 value we look for, so we want that 1 level low. So 5 in the UK, 4 in the, we're looking for diabetic patients. In the US, 200 of your cholesterol, and 4 will be equivalent to 154. So let's say about 150.
Right.
So for patients without diabetes, we say, okay, up to 200 is acceptable. For diabetics, I tell my patients, no, 154
That's
and
your
below.
marker.
That's our marker.
Right.
So everything, we say the cholesterol is lower, the blood pressure is lower, and the target sugar. So those are three components you got to look at, right? Let's look at the other one, the fourth one, kidney. We do a routine test again yearly. We check for protein in the urine. And I said to you that one of the ways of knowing if your kidney is going bad is to start looking if you're passing protein. So you can, when you pass urine, it may be frothy in the toilet. So you know, hey, something is wrong there. But what we do, we send off a sample to the lab and they check for protein. If you start seeing signs of protein in your urine in a diabetic patient, that is a serious thing. We start saying, hey, you start having kidney disease. So we call that chronic kidney disease. We start giving you medication that will, and when I go through the medication, I'll tell you some of the medications that can be used for that. So the next thing we want to look at, we talk about retinal screening. So we do annual eye checks for diabetic patients. We do annual foot checks for diabetic patients. We look at their sensation. We look at their pulses. And also we look at other things like smoking status. Depression is a big one. So diabetic patients, sometimes they go into depression. There are lots of medication. The sugar is not well controlled. So we do also annual depression screen. There are some screening tests we do for depression. I mean, again, that's a big topic we can talk about at a different interview.
Definitely.
And then there is something we do. We send them for structural. So every new diabetic, they should see a dietitian to start with their education, healthy lifestyle, food, choice of food, those things. So if we were to have those gold standards and say, okay, that's our gold standard, and yes, we will try to do as many as we can to reach that standard. Yes, we may not be able to do them all, but I think we should have that as our gold standard.
Okay. Well. I mean, the monitoring. But let's talk because you know how time runs out on this here. So, Doc, we have dealt with the complications. We have dealt with the monitoring. Tell me about treatment because this has to be very, very important.
Absolutely. Yeah. So when we talk treatment, lots of people think treatment is only medication, tablets or injections or whatever. Treatment involves, initially, I always encourage patients lifestyle advice. So I would say diet, exercise, reduce alcohol, increase your fiber intake. And in diet, as usually I said to you that we would send patients for a dietitian to guide them. But the general rule of thumb is avoid fast-acting sugar. So things like, cake, chocolate, and sweets. So you avoid that as much as possible. You use carbohydrates, complex carbohydrates. So these are whole meal stuff, whole bread, whole wheat stuff. And you don't eat big amounts or large amounts of carbohydrate at one time. You split your meals up and you use small amounts of carbohydrates. Normally, the American Diabetic Association say your carbohydrate in your plate should be a quarter. So you should have a quarter carbohydrates, a quarter protein, and half of your plate vegetables.
Okay.
Now, if you were to look at that diet, so the diet is very important. So lifestyle, I always emphasize that because also if your lifestyle is bad and your sugar is spiking, you will need more medication. So when I was trained, not so long ago, we only had about 2 drugs predominantly used for diabetes. So metformin and what a group called sulfonylureas. Now we have 5 or 6 drugs. So you have new drugs coming in the market before you need insulin. So in those days, if you've exhausted the 2 groups of drug, you go straight to insulin. That is in type 2 diabetes. Now you have 5 or 6 groups before you even decide to go on insulin. So the thing, it has changed a lot, but just to touch on the different groups of drug, because there are different indications and there are different side effects on the drug. So if we can get a slide up on the drug groups, I'll just go through this quickly, because time is of essence. Now, I talk about diabetes being a condition where there is less insulin in the body, or the insulin that is there is not being utilized properly. So what we want to do, we want to start with a drug that will make your body use the insulin better. So metformin is a group of drug that will do that. So metformin is an insulin sensitizer, so we start with that. Common side effects would be GI upset, so it can cause nausea, a bit of vomiting in high dosages. You have bloating, you have erratic bowel habits. Lots of people don't have side effects. So I wouldn't worry too much, but I will tell patients about the side effects. If they do have that, we don't stop the drug completely, we start reducing the dose. So we want to give you the dose, the highest dose tolerated. That's the concept. The highest tolerated dose. Maximum dose I will give is 2,000 milligram. That is 2 grams.
Okay.
If you can tolerate that, is good. If you can't, and also you can sometimes change the preparation of the drug from a normal release to a modified release, and you have less side effects. So that's that on metformin. The other thing to note of metformin, and I just want patients to notice, if you have chronic kidney disease, if your kidney is impaired, we also reduce the dosage of metformin. So we measure your kidney called the glomerular filtration rate, and when it lowers, we will reduce the dose to half, then stop it if it goes under 30.
Okay.
Now, the other group of drug, sulfonylurea. So in the group that we used to use long ago was the sulfonylurea group, and that is the glycoside, diamicron, glimepiride, glyburide, deonil, or glibenclamide. These are all drugs that stimulate the pancreas to produce more insulin. And then you have a group called the glitazones. So pioglitazone is classic for that. And again, they are insulin sensitizer. Also, remember the liver releases glucose as well. So you can starve, and this is a big thing and lots of things lots of people always say to me, Doc, I haven't eaten, but my sugar went up. Mm-hmm. How did that happen? It is possible because your body, if you don't eat, your brain needs glucose.
Yeah,
so your body got to produce glucose. Yeah, yeah. So there's breakdown. There's a storage of sugar in the body called glycogen, and it breaks down and releases sugar. So the liver does that.
Right.
So there are drugs that will inhibit that process. So the pioglitazone will do that. Then there is what we call a DPP4 inhibitor. These drugs are insulins. They stimulate the pancreas to produce insulin, and you have drugs like Januvia, which is sitagliptin or linagliptin. Then you have the new class of drug in the past few years, which has got lots of evidence that is very good. It also has benefits, kidney benefits and heart benefits. They're called SGLT2 inhibitors. How it works? It allows you to pass the sugar out in your urine. Common side effects, just for patients to notice, because you're peeing the sugar out, mm-hmm. you can have infection of your vagina, like thrush, mm-hmm. or your penis. You get thrush of the penis or thrush of the vagina. Mm-hmm. And that is because you have lots of sugar. So I would tell patients, if you're having those side effects of the drug, you wash whenever you pass urine. Okay. And that can prevent those infections. Yeah. So genital infections you can get. So I don't want patients, because that's a very, very good drug. It slows the progression of kidney disease in diabetics. Okay. It helps the heart in heart failure, diabetics with heart problem. So that's a new drug, well, relatively newish in that sense, that we encourage and we give patients. It's very expensive, but I'm sure it's available here as well. It's Farxiga or Farxiga in the US, Farxiga in the UK. Then you have the new, not a new drug, but a hype drug, mm-hmm. which is GLP-1 agonist, we call them. Ozempic, if you heard of that?
Oh, yes, of course I've heard about Ozempic.
So that's a family of GLP-1 agonists, and Ozempic is one called semaglutide, there is liraglutide, and there is, different types of different drug in that group.
Before I go to these questions, Dr. SAWH, mm-hmm. is that it on
that's a drug. And then once you've exhausted that list, then we go to insulin. There's different combination of drugs. Sometimes you're not eligible for them all before we go on insulin. Mm-hmm. So in some patients, I just use 2 classes, then put them on insulin. Some patients, it depends on your state of your sugar, your complications, what other morbidity you've got. Do you have heart failure? Do you have kidney failure? Together with diabetes, then we choose the best drug for you.
Look, we're going to be running out of time. I wanted to touch on Ozempic, but I'm going to have to wait until our next program to do that, because I got to get these questions.
Okay, let's go for
questions. So, and these are from our viewers. Mm-hmm. Geeta Prasad says, a fatty liver is one of the major causes of this. So again, she's talking about diabetes. So again, it is very important for you to be careful what you eat and drink. Is this true? And she
is right to say it is be careful what you eat and drink. Yes. I cannot overemphasize the role of diet and lifestyle in diabetes. But it is not true that fatty liver causes diabetes. Okay. So however, the reverse happens. In diabetic patients, you're likely to have fatty liver as well. Oh. So fatty liver, you have fat buildup in the liver, is a metabolic process, and that can, you tend to be like diabetics overweight patients are insulin resistant, they have fatty liver. And some of the drugs that are used for diabetes are used for fatty liver, like that glitazone drug, we
Okay.
can use it for fatty liver. But yeah, so she's right in a way whereby be careful what we eat, but it's not a fatty liver cause of diabetes. Diabetes is a multifactorial cause.
Yeah.
There's a genetic predisposition and there's an environmental factors at play.
Yeah. So Becky Atwaria says, my doctors say I am pre, so I start walking 2 miles a day, every day, and I do intermittent fasting. Akash, ask him what is pre-diabetes. What is pre-diabetes?
All right. So, like I said, diabetes, there are strict criteria. When we diagnose diabetes, we look at your blood level to say, yes, you are diabetic or you're not. But before you reach that level, sometimes you are higher end of normal. The high end of normal, we will consider you as pre-diabetic. So I will give you the values and show you what is pre-diabetic. So before we do that, let's go back to the diagnostic criteria that I showed the last time. So for you to say you are diabetic, there are different blood tests. So we look at a fasting sugar test. In the US is 126. So if you're above 126 and above, you're a diabetic. Random sugar, that is if you take it randomly or 2 hours after eating, 200. In the UK, 11.1, or your average sugar over 3 months, 6.5. So just remember these three types of tests and the values in that slide. You see it on screen there. And then I'll show you pre-diabetes. So your fasting sugar, we said if it is over 126, 126 and above is diabetes, but if you're between 100 and 125, we consider you pre-diabetic.
Okay.
So that is defined as pre-diabetic. That means you're not quite diabetic as yet, but your sugar is getting high. So we call it pre-diabetes. So it's the prelude for diabetes. You have your 2 hours after you've eaten or taken a glucose load between 140 and 199. That's pre-diabetic. So these are different types of sugar tests. Or if your average sugar over 3 months is between 5.7 to 6.4. Bearing in mind, in the UK and the WHO criteria, for diabetes, their values. The Americans, they were using 100 to 125. In the UK, we use 110 to 125. So there's a slight difference because the American, they were using 110 as a cutoff for pre-diabetic, but they have extended that because they claim that they are missing a lot of patients, so they prefer to have a lower value.
Okay.
But that is pre-diabetes. To understand, pre-diabetes is the milder form of diabetes in layman's term.
Great. Next question. Lizzie Parshuram says, great garlic, apply the juice, but be careful. It burns a lot and but it will be gone. Doc, what would you say about, look, there are a lot of non-conventional medicine, non-medical interventions and these things that I hear about. Actually, I know a lot of people, there's a whole host of herbs and leaves and barks and so being sold out there for the treatment of this. What do you have to say about this?
I mean, it's very, very important question, and I think I just want to shed some light on it. Now, I am not a herbalist, or I don't know a lot about non-conventional medicine. So I cannot say to you that I know this for sure will work or it wouldn't work. I always say to patients, if you're using something and you're seeing results, then maybe it is working and we need to monitor it. But we need to be cognizant of what can be some of the downside. So you're using this herb and it is helping you, you're seeing some results, but we don't know if 10, 20 years down the line something will happen. Now, anything you take in your body, there are two organs that are responsible most of the time to metabolize it, to process it. And that is your kidney would excrete it and your liver metabolizes it. So if your liver metabolizing it and then your kidney excretes it, we want to make sure those two organs are not damaged by whatever you're taking. So if you're going to take herbs, whatever you want to take and whoever recommends it, I would just tell my patients, monitor your kidney, monitor your liver, and let us see if the sugar is changing and you're having results, so be it. However, the medical evidence, I need to look at the medical evidence. We don't have lots of evidence on herbal stuff in conventional medicine, but it is used. Now, what I know for sure, there's a professor, a friend of mine, and lots of Guyanese probably know of him, Professor Jaipal Singh. He did some work, and I'm sure he wouldn't mind me mentioning his name here, but he did some work on Karila. And it is proven, and we understand the mechanism of how it works. Karila stimulates the pancreas to produce insulin.
Oh,
So
okay.
we know traditionally medicine tablets are made from plant products. So, however, what you do, you concentrate the active ingredient
Right.
and you make it into tablets.
Yeah.
So we take the stuff that is working.
Yeah.
Now, if you're taking the horrible stuff on its own, so lots of it will have the chemical in it as well.
Yeah,
But
and-
it
and
also
toxins.
and toxins.
Yes.
So that's the point.
Yeah.
So if you're going to take something that is horrible, it may have a good thing that is working, but it may have a bad thing that is not good for you. So if you're going to do that, just be wary of that and get yourself monitored.
Brilliant.
That's
All right.
that's my take on
Yeah.
horrible stuff.
All right. I have another question here. So this one I'm not going to mention the person. He says, fasting glucose is 4 to 7.2 hours after meals. Should be 7 to 10 hours. And he says, this guy is a quack. So, but again, I believe that what happened is those two units of measurement that you were talking about, one being,
Absolutely.
Yeah.
So I think I understand. I'm not offended. Don't worry.
no, yeah, please don't be. Yeah, it's just our,
Not at all. It takes a lot to offend me, so I'm not
Okay.
worried about that. Now, the point is, yes, he probably didn't hear the first part of it, that, okay, I have UK patients who are looking, so we look at UK values and we look at the US values. Now, for sugar readings, you multiply the UK value, you multiply by 18 to get the American value.
right.
And vice versa. A sugar of 10, for instance, would be 180 in the US or Guyana. Guyana uses the US value. Now, just to look at the targets, when I talk about 2 hours after eating, we aim for a sugar, ideally 2 hours after eating. I don't know, we can get that there. Yes.
Yeah.
2 hours after eating, your sugar should be less than 8.5. Generally, that's what we aiming for. That is millimoles. That's a UK value,
Right.
which is equivalent to less than 153. So let's say 100, less than 150, you want your sugar 2 to 3 hours after you've eaten. That is called postprandial sugar. Then we look at fasting sugar. Fasting sugar, we're not talking what is normal. We're talking about diabetics.
Right.
Which we are saying that if you have these targets, you're controlled. So that's a distinction to be made. I am saying to the patients, the fasting patients, your fasting sugar, should be, if you say I have good control, your sugar should be between 4 to 7 in UK value or 72 to 126 in US value. So that is your target that you're aiming for. So if you achieve these targets, you can say my sugar is well controlled.
Brilliant.
So that's the difference. And,
All right, I have one more question here for you from Mr. Akbar Ali. Now, this one is a little bit off topic, but of course we're going to take it. He said, I have ringworm in my body 40 years. Any advice?
No, ringworm is also important in diabetics, because I said to you, diabetics can have decreased immune system, so they are more prone to infection, and ringworm is a fungal infection.
Okay.
So it's a skin infection usually. It's called tinea corporis. It's caused by a fungal infection, and it's easily treated, very easy to treat. So initially, we will give topical creams and lotions, really. That's the drug of choice. However, if it is widespread in your body, then you can take tablets. There are different antifungal tablets. But yeah, it's easy to treat, and it's a fungal infection.
Last question before I ask you for closing. People has been asking, where is your clinic located?
I'm setting up now. I recently, back. I just came back, and I'll be at Woodlands. I'm trying to work at an arrangement there.
Okay.
I would want to do some charity work at a location where I can do some free clinic. So patients who can't afford to pay, for instance, they can come and see me. So as time progresses,
we'll let our
tell
public
you
know.
where, yeah.
What do you like to say in closing for this segment?
I think that we have touched a lot. Diabetes is a massive topic. Many things, we can almost talk about anything, and it can be related to diabetes. Even that ringworm, I said, is related. So I don't think we can cover diabetes in 2 topics, but I'm looking forward when we start the call-in program that there will be lots of questions.
Yeah.
And we haven't even touched on insulin, the types of insulin, and when. How do you adjust that? So there are lots. And then we want to talk a bit about Ozempic.
Yes, I have to, because there are some things I want to talk about that. So viewers, thank you for joining us on this segment. We are going to be seeing you next week again. And we're going to be dealing with another topic, hypertension, blood pressure. But Before we do that, I'm going to ask him about Ozempic next week. I know a lot of people want to know about that. So, Doc, again, thanks for being here. And remember,
You're welcome. Thanks.
everyone out there, stay healthy and look out for those who are not looking out. We have too many accidents on the road here in Georgetown. So please take your time on the road. Stay healthy.
Thank you.